Hi everyone, it's a pleasure to welcome you to today's lecture. My name is KHULOOD MAHMOUD and I'm a Martian scholar to a research to publication course developed by BMJ and UCSF. I would like to give special thanks to Dr. Nuran Hamza and Mars Group for providing me this opportunity. The topic of my lecture is adherence and complete follow-up. As researchers, we are constantly striving to produce high-quality, reliable data that can inform evidence-based practices and policies. However, one of the biggest challenges that we face in achieving the goal is to ensure that our study participants adhere to the study protocol and complete all necessary follow-up assessment. When we speak about adherence, we mean the extent to which participants comply with the study protocol, which includes taking medicines as directed, attending study appointments, and adhering to other study procedures. On the other hand, complete follow-up refers to the collection of data from all study participants for the entire duration of the study. First of all, I would like to speak about adherence and why does it matter. Adherence is crucial for the integrity and validity of any research study. Adherence ensures that the study is conducted in a standardized way, with all patients receiving the same intervention and undergoing the same assessment. Poor adherence can lead to inaccurate results, decreased statistical power, increased variability. In addition, non-adherence results in patient dropout, which reduces the sample size and limits the generalizability of the study results. How can we measure adherence? There are several methods that researchers may use, and each method has its own advantage and limitation. I will discuss the most common methods used to measure adherence. First of all is the self-report measurement. It involves participants to report their adherence to the study protocol. This can be done through questionnaires, interviews, or diaries. Number two are the bill counts, which involve counting the number of bills or tablets remaining at the end of study period to determine the participant's adherence. Number three are the biomarkers. Biomarkers involve measuring a substance in the participant's body to determine adherence, like in blood and urine samples. Number four is the medication event monitoring system, with a medication bottle or cap that records the date and time the bottle or cap is open. Number five is the nanosensors. Nanosensors in pills are an emerging technology. These tiny sensors, typically just a few nanometers in size, can be embedded in pills to monitor a patient's health in real time. The nanosensor can detect and transmit data about a patient's vital sign, drug absorption, and other health indicators. To maximize adherence, there are several strategies. Here are some of the most effective strategies. Number one is education and training. It provides a clear and concise instruction on how to follow up the study protocol. Number two, simplifying the regimens. Number three, providing reminders such as text messages or phone calls. Number four, providing incentives such as gift cards or cash and can be powerful motivator for participants. One of the most effective strategies is tailoring intervention. It customizes the intervention to meet the specific need and preferences of the participants. And last but not the least, choosing subjects that are likely to be adherent. One example of a research study where adherence is critical is a clinical trial investigating the efficacy of a new medication for a chronic condition, such as diabetes or hypertension. To increase the likelihood of adherence, a run-in period may be implanted. During the run-in period, potential participants are required to take the placebo medication for a period of time before being enrolled in the study. This serves several purposes. Number one, assessing adherence. Number two, minimizing variability by excluding participants who do not meet the eligibility criteria or have unstable disease. Number three, establishing a baseline for the participants' disease status and medicational regimens. Another aspect we are going to speak about today is completeness of follow-up. Follow-up is an essential aspect of clinical research studies, as it allows researchers to assess the effectiveness and safety of intervention over time. Our goal is 100% follow-up, and incomplete follow-up reduces the statistical power of the study and introduces bias. A widely used tool in clinical research to depict the flow of participants through a randomized control trial is the concert diagram. So what can we do to maximize follow-up? First of all, we can facilitate convenient and pleasurable study visits through flexibility and scheduling options for follow-up visits or surveys. We can also ensure that the primary research measurements are painless, practical, and interesting. We can encourage the study continuation through incentives and building rapport with participants, developing positive relationships that can improve their trust and willingness to participate in the study. We can also track down participants that dropped out. Unfortunately, loss of follow-up can occur, but if it is less than 5 to 10%, there is no cause for concern. However, if it exceeds 10%, intention to treat analysis may be biased and limits the conclusion that we can be drawn from the study. The completeness of follow-up in a clinical research is important for different types of analysis. There are different analytical techniques. They are: number one, intention to treat analysis, where participants are analyzed according to their original treatment assignment. Number two is a per protocol analysis, where only those participants who finished the research and followed up all the protocol is included. Number three, as treated analysis, where analyzed data is based on the actual treatment received by participants during the study. As an example of what we took today, there is a patient with hypertension who was prescribed a medication to be taken once daily in the morning. Adherence in this case would mean that the patient takes the medication at the same time every day and does not miss any dose. How was the adherence assessed in this example? Pharmacy refill records was used to assess adherence, where the number of medication refills and the time between refills are used. If patients are hoarding pills or getting them from other sources, this method may not be correctly reflecting real medication taking behavior. However, it can provide an objective measure of adherence and is less prone to bias than self-report. In this case, we can use one of the following strategies to encourage compliance. Number one, educating and counseling the patient about the importance of adhering to the medication and the potential benefits of the treatment and the risk of non-adherence. Number two, you can use reminder systems such as the phone calls or text messages. Number three, we can involve family or caregivers. Number four, we address medication-related concerns. Patients may have concerns or misconceptions about their medication and can affect their adherence. Number five, monitoring adherence. In summary, we can conclude that measurement of intervention adherence is essential. Maximize adherence is from the beginning. Follow-up completeness is crucial. Analytical methods can be helpful, but not if the loss of follow-up is greater than 10%. And that's all for today. Thank you.